Welcome to the Motivational Midwife. My name is Lynn Jones, and today I've put together some advice for our international candidates taking their NMC OSCE. So I was asked via email from several candidates who haven't got an awful lot of support in preparing for their OSCEs in the trust that they work. And I was going to do a sort of live Q&A session, but I felt it would probably be more beneficial to actually do a presentation on it with some general advice for all candidates for all stations. So bear in mind that this information is correct as of November 23 and that things do change. The OSCE process and some of the stations altered in June this year. So the timings were changed and 3 extra skill stations were added. So it is important, and the marking criteria became much more generic and not quite so specific. So you do need to really look at the information that your test centre sends out to you with regard to timings and other information that they will give you to help you prepare for your OSCE. There are some things that are going to be generic to all the stations, and these, remember, do all link up with your code of conduct and your proficiencies for midwifery practice, your NMC code and proficiencies. So the first thing you will do is check for scene safety. So in the OSCE setting, you're going to have to verbalise that. So you're going to need to say something along the lines of, I'll enter the room, I'm going to check for scene safety, I'm going to maintain the privacy and dignity of my patient or my client by drawing the curtains. Okay, and this, so you are actually verbalising those. You are then going to have to perform hand hygiene for all your stations, and the first time you do this, you are going to have to verbalise how you're doing that hand hygiene, and I'm going to put a link in the description box below to a YouTube video of the WHO, so World Health Organization steps for hand hygiene. But essentially, you'll say, I'll perform hand hygiene, you'll put your alcohol gel, you will have to physically put the alcohol gel on your hand and say palm to palm, dorsum to dorsum, fingers interlaced, fingers interlocked, tips to palm, thumb rotations, wrist rotations, leave to dry. And then you will put your PPE on. The point at which you actually put your apron and gloves on will be dependent on the scenario you've got. There will be some scenarios that your assessor may ask you to put your PPE on before you actually start the scenario. They tend to be more of the emergency ones, so things like shoulder dystocia, where you'll already be caring for your client anyway. Subsequent times within the scenario that you're doing hand hygiene, you don't need to verbalise it, but you do still physically need to do it while you're perhaps asking other questions. Introduce yourself to your client. So, hello, my name's Lynn. I'm the midwife that's going to be caring for you today. Can I please just check your name? Can you tell me your full name and date of birth? And then check that against the documentation you've got. Or you might say, hello, I'm Lynn. I'm the midwife that's looking after you today. Could you just give me a moment to look at your records? And then say, could you please confirm to me your name and your date of birth? And then confirm that with the records that you've got, and if she has a wristband on, with the wristband that she is wearing as well, and gain consent for whatever the scenario is. So if it's an assessment scenario in your API, you may say, I'd like to carry out your observations and etc. Is that okay? Okay, they will give you consent. So as we go through this, I'm going to take each of the stations and just give you some tips and advice that you can think about when you're doing your OSCE. So if we look at the API stations, so there's 4 stations within API, and they take about an hour for the whole 4 stations. So currently your assessment station is about 20 minutes. And again, so we've remember, you've come into the room, you've checked for scene safety, you've performed your hand hygiene, and you've taken a moment to read your scenario, and then you've confirmed the identity with her and her wristband, and ask, what would you like me to call you? Okay, so either get the history from her or confirm the history with her that you've already got on your documentation. And so it's quite useful, I found, with my candidates to use the little acronym SOMAD. So what social history have you got? You know, does she live with her partner? Is there any other children? Does she smoke? Anything that may fall into that social history. Then your O stands for your obstetric history. Is this her first baby? Confirm the number of weeks pregnant she is. Confirm if there's been any issues in the pregnancy. Confirm if there's been any issues in previous pregnancies. M stands for your medical history. So has she got any medical conditions? So, you know, asthma? Is she suffering with anxiety? You know, any medical conditions that may be relevant as well. So you need to make a note of those or confirm them. And then your A is she allergic to anything? So does she have any allergies? And D is she on any drugs, any medications? So that, if you remember that, you'll be able to ask all those questions, and they will give you a nice rounded history from your client. Ask her if she's provided a specimen of urine, if that's relevant for the scenario that you are given. If your scenario has already states that she's had urine tested, then ask your assessor, please, assessor, may I have the results of my urinalysis? Or if the analysis is on your information you've been given, then just confirm with the assessor. Assessor, can I confirm that these results are my client's urine results? Okay. When you're testing the urine, you'll be expected to do it in accordance with the manufacturer's instructions. So if you're using the multi-sticks for testing urine, that's a 2-minute period of time to test that urine correctly. So you would again wash your hands, put your PPE on if you haven't got it on already by that point. You will check that the urine test strips are in a sealed container, that they are in date, and you will verbalize this to your assessor. So you'll say, I'm happy this is a sealed container, the expiry date is, and you actually verbalize what the expiry date is. You will pick up your urine sample, and it should have your client's name and date of birth on it, and you will check that is correct, and you will say, assessor, I'm happy that this is my client's urine. You verbalize, I'm going to test this in accordance with the manufacturer's instructions. Then you will take the lid off the urine, dip your test strip in, put the lid on your urine sample, and then obviously make sure you look at the clock as soon as you've dipped that urine, and then read off each of the results at the correct time. So for example, if you're using the multi-strips, I think the first one that comes out is glucose at 30 seconds. So you will say 30 seconds glucose and read whatever it is. So it might be 30 seconds glucose negative, and then 40 seconds, 45 seconds, 60 seconds, and then 120 seconds for your leukocytes if you're using those multi-sticks, but follow the manufacturer's instructions for whichever sticks you are provided with. Once you have done that, verbalize that you're going to dispose of the test strip and the urine in the clinical waste. Okay, and then dispose of your PPE in the clinical waste, re-wash your hands, and put fresh PPE on. Gather your equipment for your observations. Ask your assessor, can I confirm that my equipment is clean, calibrated and ready for use? They may already tell you that at the beginning of your assessment, that you can assume that your equipment has been checked and it's ready for use. If they haven't told you that, then do ask the assessor, are they clean, calibrated and ready for use? And then again, back to your client and just gain consent to undertake her observations. So temperature, you're going to verbalise, depending on the equipment you've got. Often it will be a gun that is pointed at the forehead. So if it's that, you will say, I'll hold my thermometer 3 to 5 centimetres away from the forehead. Assessor, what is my temperature? And then you can ask for your temperature, or you can take all the observations first and then ask your assessor for your results. You're going to undertake the blood pressure. So you would say that you will apply, first of all, you're going to ask the client which arm would she like to use and check that she's had no surgeries or implants in that arm. Apply your cuff 2 or 3 centimetres above the antecubital fossa, and then take your blood pressure. For your pulse and respirations, you're going to say, I'm just going to take your pulse for 2 minutes, and then verbalise to your assessor, I'm going to take the pulse for 1 minute and the respirations for 1 minute. I do not want to tell my client that I'm doing this because I don't want it to affect the respiration rate. So you will have done your temperature, blood pressure, pulse. You need to then do your respiration. So you need to do your capillary refill. So you will tell the assessor, I'm going to do capillary refill, saturate oxygen saturation. So I'm going to press for 5 seconds on the nail bed, and I'm expecting the capillary refill to be less than 2 to 3 seconds, and then apply the oxygen saturations probe and take your result from there. You then need to document all your observations on the meows chart and be very careful that you document them correctly. So use the test centres should provide you with example documentation that they will be using. So you make sure that you complete the documentation in accordance with your test centre's guidance. Make sure you have put the date and time on your meows chart. Make sure that the client's details are on the chart. Make sure you have signed the chart. Highlight to your, make a note to yourself of any things that you're concerned about. Then ask your client to lay on the couch. You will have a mannequin. You are expected to talk to the mannequin as you would a real client. Okay, so direct any questions to the mannequin, not the assessor, even though you're asking the assessor. Your eye line and your questions really need to be addressed to your mannequin, not the other way around. Undertake your abdominal examination, so verbalise that you're looking at the abdomen, you're looking for any abnormalities, scars, anything that you're concerned about. Undertake your symphysis fundal height measurement. Remember, your measuring tape needs to be facing downwards so that you can't see the numbers on it, and you go from the fundus to the upper aspect of your symphysis pubis, not the other way around. Undertake your lateral palpation to determine and verbalise this. I'm going to undertake my lateral palpation to determine lie and position, and my pelvic palpation to determine presentation and descent. Then use your Pinard stethoscope to auscultate the fetal heart for a full minute, and at the same time have your maternal pulse and verbalise that you are differentiating between maternal pulse and fetal heart, and you will have to do it for a whole minute. Don't hold on to your Pinard stethoscope. Candidates do fail unfortunately for holding on to it. So once you've got your fetal heart, make sure you take your hand off the Pinard stethoscope. So do that for a full minute, and then obviously make a note in your documentation. If your assessment scenario is a potential intrapartum scenario, then you won't have a meows chart, you'll have a partogram to complete. And again, an example of that should be on your test centre's documentation that they give you. At the end of your assessment station, make sure that you verbalise that you will dispose of your PPE in the clinical waste and re-clean your hands. Go back to your client and then highlight to your client, because your assessor is listening, you know, I'm slightly concerned about A, B and C, so whatever's come up. So in her observations, it might be that you know, you seem to have some protein in your urine, your blood pressure's a little higher than I would be happy with, so I'm going to get the doctor to come and see you. So you've highlighted a couple of issues that you are concerned about. You don't need to go into your full planning of what's going to happen, just highlight those key issues to your client and what you're likely to be doing about it. So that would be your assessment channel station, and it is going to take about 20 minutes to do this station. Often your paperwork will already have your client's details printed on it, but if it hasn't, then make sure your client's details are on there. So your situation would be whatever your situation is in the scenario on your assessment station. Your background will be your SOMAD, so your social, obstetric, medical, allergy and drug information. And then your assessment, you will put down the findings from your observations and your abdominal examination and your urine analysis. So they will be what goes into your assessment station, and then your recommendation essentially is your plan of care. What do you want to happen? So depending on your scenario, that may be admit to delivery suite, doctor review within, and the time frame will be dependent on your meows score. Please do look at your meows chart carefully and learn where your parameters are for amber scores and red scores, because that will determine how quickly you want a doctor to see her. It may well be that you escalate immediately, but the doctor needs to come within 30 minutes, or it may be that actually the doctor needs to come immediately and review her. If you've got a labour scenario, is the vagina, you know, offering a vaginal examination, depending on what your scenario is, your plan of care will vary. Think about the fetus. So do you need to consider CTG monitoring? Do you need to consider a speculum examination, high vaginal swabs? Is there any bloods that need to be taken? That would become all part of your recommendations. Does she need analgesia? Then your third station is your implementation station. So your implementation is your administration of medications. Again, it's about 15 minutes. Again, be careful with your hand hygiene. So again, do you know, enter your room, scene safety, hand hygiene, have your drug chart. You'll be given a drug chart. And again, use the documentation, although there's a generic drug chart that's in the NMC OSCE paperwork, that may not be the drug chart that your test centre is using. And certainly for a couple of the test centres that my candidates have gone to, it has been a different, just recently it has been a different drug chart. So please access whatever your test centre sends you in terms of support documentation. And remember, when the test centre sends you that support documentation, it's very often for nurses as well as midwives. So you may have to scroll through it to find the documentation that's relevant to you as a midwife. Make sure you verbalise your hand hygiene again, so the palm to palm, dorsum to dorsum. Introduce yourself to the client again. Make sure that you have explained to her, I've been asked to administer your medication, is that okay? She'll say yes. Check her ID verbally with her. So can you tell me your name and date of birth? Check that with the chart and with her wristband. Okay, check that she has the correct wristband on if she has any allergies. Your ladies that are allergic to anything should have a red wristband on, and those that don't have any allergies will have a white wristband on. Then check on each page of the drug chart against the wristband that the ID is correct. So verbalize that out loud. So you might say, Lynn Jones, hospital date of birth, 13/7, blah, blah, blah. Hospital number 123456, and then on her wristband, Lynn Jones, date of birth, hospital number 123456 on each page. When you have got to the end of checking each page, you can verbalize to your assessor, I am happy that each page belongs to my client. Then you ask your client, do you have any problems swallowing? Would you like to take your medications with water or juice? Then give her the call bell. So I'm just going to go and prepare your medication. I'll be back shortly. Here's the call bell if you need anything in the meantime. Go to your drug trolley and then perform hand hygiene again. And while you're doing your hand hygiene, you can ask the assessor, is my drug trolley stocked, clean and ready for use? So hand hygiene, put your apron and your gloves on, and then prepare each drug. So on each page, verbalize which drug is there. Your scenario will tell you your time frame for the drugs. So it will tell you, please administer all drugs that are due at 12 o'clock, 2 o'clock, whichever. So although you're going to verbalize every single drug that's in that drug chart, you're only going to be preparing those that are due at your time frame. Okay, so you may say on the as required, she may have been written up for some analgesia. So you would say as required medications, paracetamol 500 milligrams to a gram, 4 to 6 hours. It is signed and dated by the doctor. I'm happy to dispense this medication or administer, prepare this medication. Just with paracetamol, just make sure that you check her weight and that she is over, particularly if you're given a range of 500 to a gram, because she needs to be over 500 kilos, 50 kilos, to be able to get a gram of paracetamol. So again, it's a safety issue. With this station, they are checking that you are safe with and that you know what you're doing. You're not just merrily administering medication because it's been prescribed. So do be aware, particularly of the most common drugs that are given, their side effects, their doses, and any contraindications that you should be thinking about. Particularly things like penicillin allergies and antibiotics. If she's got an allergy to penicillin and she's been prescribed an antibiotic that is clearly penicillin based, the expectation is that you are going to raise that as a concern, and what are you going to do about it? So if you find that she's been prescribed an antibiotic that is a penicillin based antibiotic and she is allergic, you're going to say, assessor, this client is allergic to penicillin. I need the doctor to rewrite this prescription, so therefore I will not be administering this. I need the doctor to rewrite the prescription as it's with an antibiotic that is appropriate. And then you will complete your drug chart with the correct code for not administering it and why you're not administering it. So in terms of dispensing it, pick up the bottle or the container and you will verbalize. We'll use paracetamol as an example. This container is sealed, paracetamol 500 milligrams, expiry date, and read out what the expiry date is. I'm going to dispense for 1 gram, I'm going to dispense 2 tablets, and then dispense without touching, usually pour it into the cup and then into a container that you will have already got out, and put that to one side. Each drug must be in its own cup, okay, or its own little paper container. So you will have each drug. Once you've done that, change your PPE, put some fresh PPE on, go back to your client with all your medications. Again, get her to just verbalise her name, her date of birth, and is she allergic to anything. Check it against her wristband again, and then tell her which each drug is that she's been prescribed. So this is paracetamol. It's been given for you to you for pain relief. The most common side effect is it might make you feel a little bit drowsy. So this is what you're doing. If it's an antibiotic, this is whatever antibiotic it is. It's being given for the urine infection that we think you've got. The most common side effects are kind of gastric upset, so a bit of nausea and diarrhea. Are you happy to take it? Blah, 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 for each drug. If you find a drug on your prescription chart that is not due at your time frame, you're still going to say, so for example, ferrous sulfate, 200 milligrams, and go through the whole process. When it's due 3 times a day, this is assessor, this is not in my time frame, so I will not be giving this. Okay, you don't have to sign the drug chart that you're not administering it because it's not due at the time you're doing the drug round. You are only filling in the drug for non-administration if it's due at the time you're supposed to be giving it and you are not giving it for some reason. So it might be incorrect prescription chart, it's been wrongly written, wrong dose, wrong route of administration. There may be an error on it and you're not giving it. It's due, but you're not giving it. Therefore, you must complete the drug chart in accordance with the guidelines that your test centre wishes. When she's swallowed that drug, then date and sign your drug chart. Okay, so you're signing that drug chart once you have witnessed the client take the medication. Do not sign your drug chart before they have done that. And then inform your client that you will come back in about half an hour to make sure that all is well, but give her call bell and then verbalise that you will dispose of your PPE and perform hand hygiene. Right, so your last station on the API section is your evaluation, and this has changed as of June, so this is now not a marked station but a verbal SBAR handover station. You only have 8 minutes, so I would strongly suggest you don't spend too much time on written notes. They're not marked, so you can write it in shorthand, in your own language, whatever works for you. But the key bit is giving that verbal SBAR handover, so your situation, background, assessment and recommendations. And your recommendations obviously will be dependent on the scenario that you've been given in the first place and how it has moved on. So you will be given a scenario at the beginning which will follow on from the 3 previous stations. So it may say something like, she's now spent a night in hospital, everything has settled, there's no further pain, there's no further PV loss, she's been reviewed, etc., etc., etc. So your recommendations will be different from the recommendations that were on your planning station. You should be given your planning notes and your other documentation to help you on this station. But again, check with your test centre. And then you will state to your assessor, hello, I'm Lynn, I'm the midwife working on whichever area that woman is now currently in. So she would have been in your triage area initially, or your delivery suite initially. She now may be on the postnatal or antenatal ward. So you'd say, hi, I'm Lynn, I'm working on the antenatal ward. I've been caring for blah, 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 date of birth, da, 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 who came in with, and that's your situation. Her background is she's a gravid or whatever. So use your SOMAD format. So her social, obstetric, medical, allergy status and drug status for your background. Her assessment, so on admission her MEAL score was, it's currently now whatever it is. bloods were taken for, they're all normal, whatever the information you've been given, CTG is normal, no further PV loss, no further pain, whatever your situation is, and the current situation and assessment, it will be in that assessment bit. And then, as I say, your recommendations are going to be dependent on the scenario. So if she's going home, ensure that she's all the discharge paperwork's done correctly, that she's got a follow-up appointment with her community midwife, that you've please chase any outstanding blood and urine results, etc., etc. So that will be dependent on that. So that's your API station, and collectively all of those stations will take approximately an hour. So thinking about your skills stations, you'll have 2 emergency skills stations, and currently they're about 8 minutes, and they could be any of them, but the most common ones that come up are shoulder dystocia, breech, PPH. They're 8 minutes. You get slightly longer, 15 minutes for postnatal sepsis and birth. So things that will be the same in all of them is your scene set. Or the other new ones that have been added in from June are neonatal blood glucose monitoring, which I believe is an 8 minute, but I would have to check on that. Your intramuscular injection and your catheter, removal of Foley's catheter. So things that are the same for all of your skill station is checking for scene safety, introducing yourself, hand hygiene, again, verbalize that, palm to palm, dorsum to dorsum, putting your PPE on, gaining consent for whatever it is that you're going to do, particularly around sort of IM injections, catheter removal, neonatal blood glucose. Your communication needs to be good in these emergencies with your client. So, for example, with a shoulder dystocia, you might say to your client, Lena, your baby's head is out, but the shoulder's not coming. I'm going to need some extra help in the room. So I'm just going to lay you flat. Please, I'm going to pull the emergency bell. Lots of people are going to come running into the room, but please listen to me and we'll get your baby delivered as soon as possible. Okay, so, and then you will go into your shoulder dystocia management. You need to be very clear about delegation, and you need to be able to verbalize and demonstrate the maneuvers that you are doing to resolve that dystocia or breech or postpartum hemorrhage. These emergencies, you need to be very clear about what you're doing and who you want to do it. You also need to be very clear about after the event what you will do. So, making sure that she's okay, doing a full set of postnatal observations, your documentation, making sure she's debriefed, skin to skin, and facilitating early feeding if your scenario allows that to happen, and it will very much depend on your scenario. Completing DATEXs, which is your clinical incident forms. In some trusts it's called that, in some trusts it's called DATEX, and all of these things tend to fall into the category of that need DATEXing. For sepsis and birth, you do get slightly longer, but again, for sepsis, it's about recognising that you have red flags for sepsis and what are you going to do about it. So it may well be, if you're in the home environment, it's undertaking that set of observations, doing your postnatal examination, and if it's postnatal, which it may well be, recognising that you have red flags for sepsis and what are you going to do about it. So if you're in a home scenario, it's verbalising that you're going to call a 999 blue light paramedic ambulance and transfer into hospice, stating that you have got red flags for sepsis. Okay, explaining to the woman that you have got some red flags for sepsis, you need to transfer her immediately into hospital, and then verbalising what is likely to happen. So in the ambulance, if your your oxygen saturations drop below 94%, we will give you some supplementary facial oxygen. They're likely to put some cannulas in the ambulance and start some fluids. They may well take some blood. When you get to hospital, they might put a catheter in, they will start some antibiotics, and they may take some samples. You're just verbalizing to her that sepsis 6 pathway. Also, how has the baby been? Can I get your partner to put the baby in the car seat and follow us into hospital? The neonatologist may wish to examine the baby as well. So you're verbalizing, and then after the event, this is what I would do, blah, 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 depending on whether you've got a hospital or a home scenario. If you're in a hospital scenario, you're going to pull your emergency bell and verbalize your sepsis 6 pathway. For birth, you're expected to verbalize and demonstrate your normal birth, facilitating skin to skin, talking about perineal support, examination of the placenta, so verbalize what you're looking for and that it's complete. And then following the event, so delayed cord clamping, does the partner wish to cut the cord, skin to skin, initiating early feeding, checking your perineum and vagina for any trauma and suturing promptly. All of the things you would do normally for birth, getting rid of all the soiled linen and making sure she is comfortable, and taking a full set of postnatal observations, including assessing the uterine tone and the PV loss, an ongoing PV loss. For your neonatal blood glucose, again, it's important to gain your consent, look at the reasons for why that's being undertaken, know what your parameters are for normal neonatal blood glucose for both a preterm baby and a term baby, and what you would do about it. Verbalize what you are doing, again making sure that you are checking the expiry dates and condition of the test strip box, that it's sealed, that the container's sealed, it's in date, and it's not enough to say it's in date, you have to say it expires and what the date is. That you are undertaking the blood glucose monitoring by using the correct lancet for a neonate, that you are actually undertaking it in the correct part of the baby's foot, that you're verbalizing about the foot being clean. There is a YouTube video. It's meant for nursing and adult blood glucose monitoring, but I'll try and put the link in the description underneath, but that does have some information that you can actually transfer over to neonatal blood glucose monitoring as well. For IM injection, again, you're going to be checking your prescription chart and everything just exactly as you did for your implementation chart station, but you need to make sure that you have checked all the packaging dates, that they are in date. So for your needles, you're drawing up needles, your syringe, all of those things are in date, that your sterets and all of those are in date. Checking your medication, again, that it's in date, sealed containers, drawing up the injection, and then obviously administering it as per national guidance. Again, I will put a link to a YouTube video that can be quite useful for that as well. It is an OSCE practice video, and that you talk to her about the localized side effects of that injection as well. Removal of catheter, again, I will put a link for that video down as well, but your aftercare is very important. So talking to her about measuring the first void after the catheter's removal, about the amount of fluid that she should be trying to drink, and the sort of common side effects, like it may be a little bit stingy post removal when she does try to pass urine. So another station you will have is postnatal examination station. There's 15 minutes for this station currently, and again you will do some of the same things exactly as you have for all the other stations about checking for scene safety, maintaining your dignity and privacy, your hand hygiene and putting your PPE on, introducing yourself, review the notes and gain consent for that postnatal examination to be done, and then do your top to toe examination. And again, I have a whole video on postnatal examination, which you can will be in your NMC OSCE playlist. So I'm not going to go into that in depth. Undertake observations if your scenario is appropriate. Talk about health education. So you'll be expected to talk about breast care if she's breastfeeding. Talk about positioning and attachment, talk about perineal care, talk about how often she should change her pads, signs and symptoms of deep vein thrombosis, things to look out for. And then complete the documentation. So there will be documentation for you to complete. Please use the documentation that your test centre provides you with, and make sure you date and sign it. And the NIPE examination is your other station, and you have 25 minutes currently to do a NIPE examination. And again, very similar to the others about scene safety, hand hygiene, introducing yourself, gaining consent, read your scenario, review your notes that you're given. So you want to know about the birth, you want to know any risk factors that might be there antenatally. Ask the client, does she know about newborn infant physical examination? Discuss what it is, when it's done, the purpose of it, and gain consent for doing it. Before you actually start, ask about how the baby's sleeping. Has it had its bowels open? If so, what colour is it? That will give you an idea as to where we are. If we've got a changing stool already, then that baby is clearly getting quite a lot of feed through. Has it passed urine? How's the feeding going? You can talk to her about if she's saying, I've got problems attaching the baby, you can verbalize, after the examination I will come back and go through fixing an attachment with you. Okay, don't use your NIPE time to discuss that at that point. And then undertake your top to toe examination. You will be asked to focus on 2 of the 4 standards, and you will be expected to know the pathways for those 4 standards. So for screen positive means there is a problem. Screen negative means there isn't a problem. And so if something is screen negative, the baby will carry on the Healthy Child Programme and be reviewed again at 6 to 8 weeks by the GP or a health visitor in the primary care setting. And if it's screen positive, then you'll be expected to verbalise what the pathway is for a screen positive for any of those 4 key standards. You'll be expected to then complete the documentation that your test centre gives you. And as I say, all the way through, think about health education. So talk about cord care, talk about the icon leaflet, so it's normal for babies to cry, check the nappy, feed them, don't shake your baby, put your baby somewhere safe and in the cot, and then go and get yourself a drink if the baby's crying is really getting to you. See if there's another adult in the house that can perhaps help you. You can the icon leaflet is available in all trusts, and I believe you can access it online as well. I'll try and put a link to it again in the discussion page, so you've got that to look at and the advice you should be giving. There are videos on the NIPE within your OSCE playlist, so you know how to actually undertake that examination. And then your silent stations, You have your evidence-based and your professional values. These are 10-minute stations, so it'll be 10 minutes each station, and they usually run back to back. Don't forget to sign and date both stations. So finally, make sure you engage with the resources that your test centre sends you. Watch the time, okay? You can run out of time very, very quickly. Practice, practice, practice. I would say record yourself on the phone and then listen to it back, because you will then see where the bits are that you've missed out. Write yourself a little checklist of things that you need to cover. Look at the marking criteria, so that you can make sure that you actually are following best practice, and access help if you need it. Your practice development team should be there to assist you if you need it, even if you haven't got any formal training support within your trust. Your practice development team should be there to support you get through this OSCE. And good luck. And there you have it, some advice for the international candidates taking their NMC OSCE. I hope you found it useful. If you haven't subscribed to the channel already, please do so, and I look forward to seeing you next time.